Yeah, yeah, yeah.
Wait,
Now,
wait. It is yet to. Now we are live. Yes.
yeah. Good evening, everyone. Welcome to this 79th masterclass. And today's topic is the ovulation induction protocols in adenomyosis in natural cycles. And before we actually formally start the class, so today we had an excellent post by Dr. Jay in all the WhatsApp groups about the en bloc removal of the endometriosis from the skin to almost into the uterus. So if you can just tell one or two sentences about it as to how different was it, why was it done as an emergency, it would be good because again, it is the same complex of endometriosis, adenomyosis that we will be discussing today, though your case was a hysterectomy.
Yeah. No, she had a huge endometrioma penetrating from the skin till the almost myometrium. Okay. Subendometrium, basically. And she was on it for the last 10 years. So, multiple episodes of everything. She was on Dino on her own because the husband is a pharmacist. Then multiple things. So Dan has all this, that, and see, nothing works. Everybody knows that. But the size just kept on growing till it reached the skin, and she started discharging blood from the skin 3 days back. Okay, and that is when she got really scared. She used to be admitted in the hospital every menses for taking painkiller injections. Okay, and I mean, I think once she was told that she needs to get a surgery done, but I don't know. She never got it done.
Mm.
Is my voice clear? Somebody's writing voice is not clear.
Can you take off those AirPods? I don't know. I mean, whether that is the one which is, it's slightly different. It's not about the clarity. Can't hear. You need to switch off the this thing from the AirPods, the voice.
Yeah. Is it better now?
This is much better, much better. Thank you.
Okay.
Yeah.
Yeah.
So,
So
huh.
she ended up with that. I mean, it was a bad case. Right from the skin till the uterus, everything had to be removed. She had small bowel infiltration, she had bladder infiltration, and it's sad, no? If something so small as this could have been managed with a simple surgery, we ended up doing a block resection, put a 15 centimeter mesh inside. We posted the photos of all those things. So it is okay, but it is not good for the patient ultimately. And I think the learning point is, see, we do understand that many a times people want to do everything on their own and not want to refer. That is understandable. But at least do it. Okay, don't ignore it, because when you ignore it, then it is a big headache, in my opinion.
Yeah, yeah. So let's start the class on the ovulation induction protocols.
Yeah. Uh, okay. So I think you can see the screen, right? Is the screen visible? Can you see the screen?
Yes, yes.
Okay, fine. So we will start. See, we are going to be discussing natural conception protocols. Okay. And we are going to be discussing it with adenomyosis. So, rules of adenomyosis are very simple. I will give you a flow chart as to how you are supposed to do natural conception cycles with ovulation induction. Okay. And it is really, really a very simple game plan which you should follow. Okay. So, first is you will divide adenomyosis into three parts. One is diffuse adenomyosis, commonest. Second is focal adenomyosis, second most commonest. And third is focal adenomyosis of outer myometrium. That is the third most commonest. Okay. Now, in focal adenomyosis of outer myometrium, all right, rules are very simple. Nothing doing. First thing is to do laparoscopic surgery. Okay, and then do stimulation. No other rule. Okay, no questions to be asked, no other rule. The answer is to do laparoscopic surgery only. Okay, then when I move on to focal adenomyosis, in focal adenomyosis, again, it is very simple. Is the focal adenomyoma less than 3 centimeter? Is the focal adenomyoma more than 3 centimeter? If it is more than 3 centimeter, again it is very simple. You need to do laparoscopic surgery and proceed with stimulation. If it is less than 3 centimeter, okay, then in that situation you can give a combination of registerone plus letrozole. Okay, this letrozole is 2.5 mg, and you need to give this for 100 days, as we all know. And after this 100 days, you proceed with stimulation. Okay, and finally, we come to diffuse adenomyosis. Diffuse adenomyosis is again very simple. Is the size of the uterus more than 10 centimeter, or is the size less than 10 centimeter? If the size of the uterus is more than 10 centimeter, the answer is again very simple. You need to do a laparoscopic surgery, okay, debulk it, and then proceed for stimulation. If the size is less than 10 centimeter, then your option is you give letrozole plus registrone for 100 days and then proceed for stimulation. All right. Now, if you understand this much, there is only one another thing which you need to know when you are treating adenomyosis. Okay. When you treat adenomyosis, remember that husband has to be absolutely normal. Fallopian tubes have to be absolutely normal. And both these are possibilities when you have adenomyosis. Only case where it is not going to be existent easily is focal adenomyosis, because it also causes deep endometriosis almost in 100% of situations. Okay, this is 100% correlation. So what is going to happen is husband normal, fallopian tubes normal. In that situation, okay, you can proceed for natural cycle stimulation in any of these situations. Okay, one more thing which you need to know and which you need to understand. Okay, we always say that endometriosis is associated with low AMH. Adenomyosis may or may not be associated with low AMH. Okay, it may or may not be associated with low AMH, as a result of which, if you select your patient correctly and if you use this protocol nicely, after using this protocol and then doing the stimulation, you will have a very, very good chance of the patient becoming pregnant, as long as there is something called as endometrial myometrial junction. As long as the endomyometrial junction is preserved. Okay. Now, endometrial myometrial junction is something which you can best study in the follicular phase, especially between day 6 to day 12 of the menses. And you will see an unhealthy endomyometrial junction will have some separations like this. Okay, there will be haziness at the endomyometrial junction. And usually, if there is haziness of the endomyometrial junction, the answer is simple. No matter what you do, okay, results are very poor. Okay, just keep that in mind. So with this much knowledge in your head about adenomyosis and how to approach adenomyosis, let us quickly go through the standardization of protocols which we would want to have once we begin stimulation in any form of adenomyosis. Okay, so the answer for again stimulation protocols is very simple. Do you want to stimulate the patient for natural cycle, or do you want to stimulate the patient for IUI? Okay, so we have divided the patient for natural intercourse cycles or the patient for IUI cycles. This is again very simple, and here we go. Protocol of choice. Our first thing, we have already answered this multiple times, but I will write it always. It is always going to be combination of letrozole 2.5 plus highly purified human menopausal gonadotropin 150 international units, and this is to be given for 7 days. Standard protocol, nothing to be changed. Okay. Trigger of choice. Trigger is always going to be 10,000 hcg, no thoughts. I know Here, a lot of people are going to ask this, so I will write it categorically. Avoid loop right, because it will just screw up the entire natural cycle. Okay. Lot of people will also ask a question that instead of letrozole plus registrone, we want to give pre-treatment with GnRH agonist depot. Okay, good. I really appreciate it, but please compare it once with letrozole plus registrone. And the minute you do your first patient, you will switch to almost everywhere giving letrozole plus registrone, because this is one protocol which causes significant volume reduction and simultaneously significant improvement in the endometrial myometrial junction. You will see this when you give it. Okay. Luteal phase support. Luteal phase support is always in the form of progesterone gel, and progesterone gel 8% is to be given twice in a day. Expected success rate in this case of natural cycles is going to be around 6 to 8%, and IUI cycles is going to be around 12 to 13%. Okay. Remember one thing. The treatment of choice is always going to be to not operate a patient in adenomyosis. The treatment of choice is always to not operate. Okay, we never want to operate a patient of adenomyosis, because once you operate a patient of adenomyosis, okay, that will itself reduce the success rate by approximately, let's say, 10%. Okay, even if you are the best surgeon on earth, it will cause gross, distortion of the endometrial cavity, and it will almost always affect the fallopian tubes unless it is a focal adenomyosis surgery. Okay, your surgeries for diffuse adenomyosis, no matter what you do, are going to go and are going to affect the fallopian tubes. And if they affect the fallopian tubes, you are only going to be left with IVF as your option in treatment of these patients. So please remember, though I have written down surgery at two places, apart from focal adenomyosis of outer myometrium, that does not cause distortion of the endometrial cavity, where I have written surgery is the primary option. And second, I have written focal adenomyosis, more than 3 centimeters. That also does not cause fallopian tube damage. The one who causes fallopian tube damage is surgery for diffuse adenomyosis. And the problem in surgery for diffuse adenomyosis is it always goes on to the fundal region also. It is never going to be only posterior. It goes to the fundal region also. So I will just draw and explain something which I have learned the very much hard way. Okay, so if people see, they will realize why I'm trying to tell something like this. Okay, see what happens is, whenever you are trying to look at a uterus which is a normal uterus, something like this, endometrial cavity is here. Patients with diffuse adenomyosis will have a uterus which is, let's say, like this in shape, and the endometrial cavity is here. So what it actually does is, see, there is a difference which starts from the anterofundal region till the fundal region till the posterior region, and when you come close to the internal os, when you come close to the level of the internal os, there is actually no adenomyosis there. The adenomyosis never happens in the cervix. Okay, or I mean, what I mean to say is, there is very minimal infiltration in the cervix. Now when you want to do this surgery, and if I look at the cavity, see, this cavity from inside will look like this, normal cavity. But a cavity of this guy, the cavity of this guy, the fallopian tubes are somewhere here. Okay, remember, fallopian tubes are here. So this cavity is going to look like this. Okay, so what happens is, when you correct this part, when you do debulking from here, let's say this is your line of debulking, you may just touch the endometrium and you may debulk something like this. In this line of debulking, a part of this fallopian tube and a part of this fallopian tube gets permanently damaged, and also because it gets stretched due to your suturing, this cavity then becomes something like this. It becomes a cavity which is like this. So many times in your follow-up images, you will see something called as a tubular cavity, which forms after surgeries for diffuse adenomyosis. And the reason it forms a tubular cavity after diffuse adenomyosis is because you are doing something called as flap surgeries. Okay, as a result of this, okay, now people who don't do this so many times in their clinical practice might not be able to correlate. They will just give you some random answers. But if you are doing it up and down daily, on a huge scale, you will understand that this is the biggest problem which occurs to the patient. And because this is the biggest problem, I mentioned that surgery should be the last thing which you should be doing in this adenomyosis patient, unless the size criteria is such. So now somebody will ask, what if the size is 12 centimeters? I want to go ahead with stimulation. Go ahead, but the patient will never become pregnant. Okay. The thing is that size of the uterus requires debulking. The uterus size, which is ideal for conception, is 100% somewhere around 6 to 8 centimeters. It is not that size of 10 and 12 centimeters. Okay, that 10-12 centimeter size is a uterus which can conceive when it has a fibroid. Understanding? It is not when it has adenomyosis, because in fibroid there is no myometrial thickening. There is myometrial thinning which occurs due to the presence of fibroid. Adenomyosis is exact reverse. It causes myometrial thickening. Understanding? And that itself causes a very bad endometrial milieu. And this bad endometrial milieu is going to 100% ensure that the patient does not become pregnant. Okay. So with that, I conclude the stimulation for natural cycles, and we can answer questions from Madam.
So you think a focal adenomyoma is better than diffuse adenomyosis in ovulation induction for natural cycles?
Yeah, less than 3 centimeters, then yes.
Okay, and see, adenomyosis again has the defective endomyometrial junction or cystic spaces in the myometrium or the volume of the uterus as a parameter to diagnose adenomyosis and its severity. So among these three factors, which one do you think has the major contributor?
Volume.
You think the volume or it is the endomyometrial junction?
No. Volume is the first thing, madam. See, you can have like a 10 centimeter uterus with a great endomyometrial junction. The patient will not become pregnant till the size becomes less. Or you can have a 6 centimeter uterus with a poor endomyometrial junction. On this poor endomyometrial junction, if you give letrozole plus registrone, okay, then that endomyometrial junction will at least improve. What is endomyometrial junction? Actually, endomyometrial junction is a marker of the severity of the component of adenomyosis. Correct? It does not really develop on its own. Okay. The endomyometrial junction is the worst when you have diffuse adenomyosis. Why? Because it is diffuse adenomyosis. The endometrial myometrial junction is the best when you have focal adenomyosis of outer myometrium. Why? Because that is a component which does not even come in the endometrium. It is actually a deep endometriosis which has infiltrated the uterus. Understanding? So, if you understand the concept of adenomyosis, then you will realize that first you want to go and target is the volume. Once the volume goes down, okay, automatically the endometrial myometrial junction may improve.
Okay. So, one of the factors in adenomyosis is the hyperactivity of the myometrium. So, through the cycle, would you like to give Buscopan or any kind of antispasmodics, especially
See, we
during?
tried giving Eugesic, okay, that is Piraxicam. We tried giving that. I don't think it really benefits, madam. Again, I'm telling you, if the volume of the uterus is less, you don't have to worry about endometrial myometrial contraction, nothing. Okay, that uterus will only take care. It is the large volume uterus which has these abnormal contractions.
So, endometrial receptivity again has been a cause of concern in terms of adenomyosis for various reasons. So, do you add anything as a supplement or as an adjuvant to improve the
No,
endometrial receptivity? Does it really
no.
matter? And do you think the dosage of medications or the number of days that you do the stimulation, is it more in cases of adenomyosis or is it not
Same.
much of change? Okay.
It is the same.
Yeah. So many a times we see that adenomyosis is associated with low AMH.
Correct.
So in such situations, do you think doing TVOD will help in natural cycles? Have
No,
you tried doing that?
no, it will not help, madam.
What about embolization? I mean, I know for fertility preserving embolization is something which we, as fertility consultants, we don't really go for embolization. But post, have you seen any patients who have had embolization for large diffuse adenomyosis and then come back for stimulation protocols? How different is it?
They are non-responsive in the endometrium.
Hmm, hmm, hmm.
It sounds very cute, you know, to embolize the uterus. But the problem with this embolization, no, no, don't laugh. The problem with this embolization is it destroys the endometrium. People don't understand that because the emboli, it actually goes and feeds itself into those arborizing vessels. They are end arterioles. Okay. So, uh, it is a method of contraception, basically, embolizing the uterus.
So adenomyosis, I think, has been a disease of slightly older women, and now we are seeing more because of I mean, lifestyle changes and women trying to postpone family, and we are treating more and more of these older women for fertility. So at the same time, we see severe adenomyosis in younger patients too, where I think you have only done many surgeries in Bangalore who are like 28, 29 with huge uterus. Even this time we had somebody who was almost having a 16 centimeters adenomyoma. So in these situations, like of course, age is one of the most important factor which determine the fertility. But do you think adenomyosis is more aggressive in younger patients if it starts coming in an earlier age? Or do you think I mean, it doesn't matter. It is just the individual individualistic criteria or their tendency to develop adenomyosis?
I think it is an individual criteria.
Okay. So what is the role of Mirena before we actually go ahead and stimulate? Many people may not be competent enough to do the surgery of diffuse adenomyosis. So if the uterus is between say like 10 to 12 centimeters or 10 to 14 centimeters,
No
can
role.
Mirena?
No role. See,
Okay.
remember one thing. In order to reduce the volume of the uterus, you have to provide the uterus with an anti-estrogenic component. That is the reason why the volume of the uterus reduces after menopause. Because in menopause, it is the estrogen which goes down. Nothing happens to the progesterone. Understanding? This is the concept which people should figure out when they want to do volume reduction. So when you are giving luprite depot, you are basically down regulating the receptors and achieving a volume reduction, which is not a very competitive volume reduction for that uterus. If you give 100 depots in your life, and even if you have invented the depot on your own, you will agree to the fact that the volume reduction in adenomyosis after a depot is not even 10%. Okay. The beauty with regestrone plus letrozole combination is that one, regestrone provides continuous progesterone just like how Mirena would provide, which would cause down regulation of progesterone receptors in the focal regions, okay, where adenomyosis is active. And simultaneously, when you give letrozole will induce thinning of the myometry, which is what you want. Okay, that is the only way in which you can reduce the volume of the uterus. But this will not act once the size of the uterus crosses 10 centimeters. The reason for this is simple. Till the size of the uterus is 10 centimeters, okay, the usual distance between the endometrium to the posterior serosa or to any part of the serosa, okay, is not going to be more than 3 to 5 centimeters. Once this size crosses 10 centimeters, then that distance is huge. So what will happen is you will have patchy places where there is effect of letrozole plus regestrone. The other places there will be no effect. Okay. Other places there will be no effect. So many a times people have said, will it work when a uterus is 9.7 by 7.8 by 8.2 centimeters? Okay. The answer to that is it will not work in that case also. If it is a bomb, no, if it is that globular bomb, okay, that uterus will require surgery. 100%. It is just too big a uterocervical length for a drug to go and act.
Yeah. So, young girls with diffuse adenomyosis, which we see, like who are not yet married,
Yeah,
how do you tell them about fertility preservation? Or like, I mean, because this is a progressive disease, as we know.
yeah.
So, input on that.
Honestly, these young girls, if they are opting for surgery, we have counseled so many of them to opt for egg freezing also. Okay. Because that is one of the best ways to preserve the fertility in these girls. Second thing, because it is a progressive disease, if they don't get married on time, see, we have been very unfortunate that we end up getting surgeries which have been supposedly operated once before. Correct. Where a small focus is removed of adenomyosis and rest is left as it is. Okay. The worst surgery to get is a repeat adenomyoma surgery. Okay, because it is very, 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 very bad. Okay, it is very bad surgery to do. So my humble request to everyone is, if at all you have to operate, please send this surgery to somebody whom you think is an expert. Okay, but it has to be operated nicely, otherwise the fertility is screwed up.
Okay. So the another challenge that we face in adenomyosis with this ovulation induction is the thin endometrium.
Yeah.
What is it that you would change in your protocol to have an optimal endometrial thickness, or do you bring down the criteria of normal endometrial thickness in adenomyosis cases?
The answer to that is in the endomyometrial junction. If the endomyometrial junction is good, you will get a good endometrium. Okay,
Mm.
because the endometrium will grow based on follicular response. If the endometrial myometrial junction is distorted, then no matter how good the follicular response is, your response to endometrium will be very poor due to patchy vascularity.
Okay. So in your center, I know it's a referral infertility unit. What are the numbers like? I mean, is it like if you do 100 cycles of say natural cycle and UI cycles, how many of them would be for
20,
around
15 to 20.
15 to 20%?
Yeah,
Okay. And do you see any change in the success rate in
it is
the
lower.
it's 5% lower, you can say?
Yeah, 100, it's 100%, 5% lower.
And do you counsel them even before you start the stimulation, saying that this is what you can expect as your
Not now, because they only come with that mindset. Somebody has told them if it is endometriosis or adenomyosis, you go to him only, do what he says, something like that. So that question of counseling now doesn't arise. But yes, in initial practice, we were counseling.
so have you used clomiphene citrate in these cases, in adenomyosis cases?
No, I
No.
don't like it much.
Okay. And I know letrozole is an anti-estrogen. So do you do purely the gonadotropin cycles anytime in adenomyosis cases?
No, always both. Because I don't want the estrogen values to peak up.
Mm, 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 mm. Yeah. Yeah. Do you think steroid really helps in adenomyosis in terms of like inflammation and steroid being an anti-inflammatory?
No,
Uh,
it has got no role.
Not really. Okay. Yeah. I think, yeah, it was wonderful. I think there were a lot of points which have not been mentioned anywhere, which I think is purely because of your practical experience, being such a good laparoscopic surgeon, dealing with so much volumes and also dealing with so many cases of adenomyosis, endometriosis, cases in infertility that you have been able to actually, I think consolidatedly put it in this class. It is a great help for everyone who will watch this class. I think this is one of the very good class on adenomyosis that I can say. Thank you very much for your time and your teachings. Thank you.